to thank Dr. Jane and Dr. Willis for organizing today's interdisciplinary trauma event. Lots of diligent work recruiting speakers, and we're so grateful for all the faculty that were able to join us today. Thank you so much. You've really elevated the quality of our interdisciplinary trauma day today, and we're very appreciative of it. Dr. Jane.
So next, we have Dr. Fox. Dr. Adam Fox is coming to us from Rutgers University, and also in Newark. So he's the assistant, sorry, excuse me, it's all right. So he's associate professor, assistant professor of surgery. He's the section chief of trauma, and also is, he's got a lot of titles happening in there. Most importantly, he went to college with Dr. Silverberg. If you want to get inside stories, this is the man to ask. And who also recruited him and is here because of Dr. Silverberg. So I'd like to thank Dr. Silverberg for introducing us to Dr. Fox. And without further ado, please, welcome.
Thank you very much and good morning. I really do appreciate the invite and the fact that all of you are here on a Wednesday morning to listen to me talk to something slightly different than what you've been hearing through the morning. The title of this talk is Trauma and American Presidents. What I will be doing is reviewing the medical care that each one of our assassinated presidents and attempted assassinations to our presidents, what kind of care they got. The exercise of this started, I always have to put down I have no disclosures. Nobody is interested in me enough yet to provide me with any money for anything. So because this is an academic talk, we do like to have some objectives. So grossly, and the 30,000-foot view is, we're going to review really how trauma care has evolved, or really maybe not so evolved since the assassination of President Lincoln. We're also going to understand the medical preparation needed to care for the president. As you might imagine, the President of the United States might require a different type of setup and evaluation process and even treatment process than regular lay population. And then ultimately speaking, we're going to delve into each one of our presidents who were assassinated or with an attempted assassination to find out what medical care they got. And one of the things that I really want you to do, and I'll stress this again as I start with the actual presentation itself, is I want you to think about if these patients were coming into your emergency department. If you were working down in the trauma bay when this particular type of problem came in, how you would approach it. And then we're going to talk about how the physicians at the time approached it, and then we're going to actually weigh in on whether or not we think that they did a good job or not. So let's really get into this, the nuts and bolts. Trauma to world leaders is a very interesting topic. What actually got me interested in this topic was a godlike trauma surgeon in this country, or at least he thinks he's godlike, decided that, or I heard this guy giving a talk about Princess Diana and her medical care at the time of her death. And it really kind of got me thinking to myself that there's a lot of things that happen during these processes that are very interesting, and for a medical professional, it becomes very academic and kind of exciting to hear what happened to these people, how they treated these people, whether or not it was appropriate, and what the eventual outcomes were. But there's a lot of things that happen with these patients that are in evolution. Just as in all medicine, medicine evolves over a period of time. And you'll see here from the time of Lincoln to our most recent assassination attempt, there have been major changes in the way we take care of our patients. One of the things, though, that you will identify or you will hear about during this talk is that there's a huge amount of secrecy involved with these patients. There are a lot of conspiracies that are theories that are associated with it. And ultimately speaking, we are not truly going to ever get a great picture of what happened because of some of the secrecy that is involved. One of the other things that we're going to touch on is how we prepare and what the chain of command is in association with injured presidents. So I'm going to do this talk mostly with case presentations, and then we'll discuss things immediately. Some of you will probably be able to guess some of them immediately, and others may be a little more difficult unless you're a student of history. So our first case is going to be a 56-year-old male patient who was shot to the head with a .44 caliber single-shot Derringer pistol. You don't hear about those pistols very often anymore. Most of the time you're hearing about these multi-ammunition rifles that are being used. But 44 caliber single-shot Derringer pistol. The primary and the secondary survey were done. There was no movement of the artery at the right radial artery. He had been shot in the back of his head behind the left ear. I easily removed the obstructing clot from the wound, and this relieved the pressure on the brain. We all know who this is? Lincoln, very good. But what I want you to do, again, as we're doing these case presentations, is think about what is going on from a medical perspective, how you would treat these patients. Does this sound sort of familiar to you? Relieving pressure on the brain. I took clot out, and I'm relieving pressure on the brain. These are patients who sometimes have intracranial pressure problems, right? You relieve the clot, and you relieve the pressure. So already in the 1860s, they recognized that they had to do some type of decompression. We continue on with the physician who first treated him to revive by artificial respiration and introduce 2 extended fingers of my right hand as far back as possible, and by pressing his paralyzed tongue downward and outward, opened his larynx and made free passage of air into his lungs. I placed an assistant at each of his arms to manipulate them to expand the thorax. I think about this, like you sort of make the guy fly. And then with strong thumb and fingers, applied intermittent sliding pressure under and beneath the ribs, stimulating the apex of the heart. What does that sound like? It sounds like CPR, right? When was CPR first really discovered or utilized in the United States or in the world? In the early 60s, yeah. But it's amazing and fascinating. This is one of those things that I was talking about when I started this discussion, the way things have evolved. We have been doing a lot of the same things for years and years and years. We just have different names for it. And they might get tweaked and they might get better and evolve over a period of time, but they were doing some sort of CPR way back in the 1860s. Ultimately, they got return of spontaneous pulses and respirations. Intermittently, they cleared the clot from the gunshot wound. And as well, they probed the wound with both ungloved fingers and a probe up to 5 inches. Do we need to do that nowadays? No, not usually. Although I do probe gunshot wounds, I usually don't do it in the brain. And I don't recommend my residents probing anything. But I tend to use, if I think there's a tangential wound, I actually will use an NG tube and I'll put it in and see how it tracks. But you have to have a really delicate hand for that. So I don't recommend it. So this is Abraham Lincoln, our 16th President of the United States, as you all very astutely guessed. He obviously is a very famous character. You all know a huge amount about him. What you may not know is that other than the fact that he was hugely unpopular, there were about 10,000 death threats that he had prior to his assassination because of the distinct separation between what people believed in the North and the South. This is a picture of Ford's Theater where he was actually assassinated. So a couple of entities, or a couple of aspects about what happened that night, and this is the history part of this. There was some talk that Abraham Lincoln, just prior to his assassination, dreamed of his own death, and this is documented in several places. So at the end of the war, him and his wife and a major in the army, they and his wife decided that they were going to go decompress a little bit while seeing a show at Ford's Theater. Normally speaking, President Lincoln did have a bodyguard, but there was no Secret Service at the time who had a whole detail for the president. It was just one person. That one person was actually on a mission, and they had another police officer who was assigned to him despite some objections by some of Lincoln's staff. Lincoln ended up going to Ford's Theater with this guy, John Parker, who was the police officer assigned. John Parker deposited Abraham Lincoln in the theater and then promptly went across the street to the bar that was there and started drinking. Lincoln got there around 8:30 at night after the show had already started. And then we'll take a little break and talk about some of the perpetrators of the crime. So John Wilkes Booth was the one who assassinated President Lincoln. The rest of the people on this list were actually co-conspirators And the way this evolved over the period of time was John Wilkes Booth was actually born in Maryland. He was an actor, so he actually knew the show that was being played that Abraham Lincoln went to. He had decided originally, him and his co-conspirators were going to kidnap the president, hold him for ransom for prisoners of war from the South. But now that the war was over, they decided that the best route of action, or course of action, was going to be to kill the president. So these are his co-conspirators. They were going to go to the Secretary of State's house and the Vice President's house, while John Wilkes Booth was going to take care of the president himself. During a particular line in the play where there was going to be expected laughter, so nobody would hear the gunshot and he would be able to get off scot-free. So he comes in to Ford's Theater early and found that it was well before the time in the play where there was going to be this laughter, and he decides to also leave the theater. He went across the street to the same bar where President Lincoln's bodyguard was drinking and drank in the same bar. Nobody knows whether or not they drank together, but he ultimately came back in, approached him from the right-hand side, and fired his gun. Major Rathbone, who was the Army major in the party, tried to stop him and was actually injured with a knife that Wilkes Booth had with him. And then John Wilkes Booth, what did he do? He jumped from the balcony saying "Sic Semper Tyrannis," which is down with tyrants, and subsequently did what to his leg? Does anybody know? He broke his leg. He broke his fibula, actually. So this is an example of the trajectory of the bullet that went into Lincoln's head. Again, if you're getting somebody like this, I want you to think about whether or not this is a survivable or non-survivable injury. It may not be survivable, but it's a unihemispheric gunshot wound. It's possible that he would have survived off of this, but this is the trajectory through Lincoln's head. What happened next was the multiple physicians started arriving. Charles Lyell was right out of school, and he was the one whose report that you heard at the beginning of this, documenting his efforts at resuscitation, as well as clearing the plot. The Surgeon General and the Assistant Surgeon General arrived. Dr. Stone is one of the personal friends of the Lincoln family, and ultimately they decided to transport the president across the street to a private house. They performed a trajectory assessment, and again, we talk about trajectory assessment all the time. We want to assess which way things would go. We want to triage those cavities to identify what may have been injured. They were doing this way back when in the 1860s. They did this with a probe at the time, and they encountered a foreign substance. They continued to re-clear the clot. Ultimately speaking, however, as you all know, his pulse and respirations continued to decline, and he died at 7:20 in the morning, ultimately bringing his body to the White House, where an autopsy was performed. So the White House has a bowling alley in it, a movie theater in it, and also, I guess, a morgue. This was performed, and from the autopsy results, the ball entered through the occipital bone about 1 inch to the left of the median line, and just above the left lateral sinus, which it had opened. It then penetrated the dura, passed through the left posterior lobe of the cerebrum, entered the left lateral ventricle, and lodged in the cerebrum just above the corpus striatum, and the orbits were engorged with blood. Again, with the picture of the trajectory to help you identify. So what happened after that? Obviously, Lincoln he laid in state for a little while, went back to be buried in Illinois, but John Wilkes Booth had escaped, and he eluded capture for a few days. One of the places that he actually went to was a doctor's house by the name of Dr. Samuel Mudd. He was disguised. Nobody's really sure if Samuel Mudd really knew that this was a plot, but he took care of him nonetheless. John Wilkes Booth then essentially barricaded himself in a farmhouse. And this gentleman, this interesting gentleman, one of the themes of this talk is that the people who shoot other people are really interesting characters. And when I say interesting, I mean crazy. This is an Army officer known as Boston Corbett. Boston Corbett was from the North. He was a religious zealot who, the story goes that he was approached by a prostitute, and because of his pure thinking, thoughts when she approached him, he self-castrated so that he wouldn't have these thoughts anymore. But nonetheless, he was in the army. He was in the army that surrounded John Wilkes Booth in the farmhouse, and without any orders, they lit fire to the barn so as to get John Wilkes Booth out. Ultimately speaking, all the conspirators also were tried and hanged, and Samuel Mudd, the doctor who actually took care of John Wilkes Booth, was sentenced to prison down in Florida, and but he was granted early parole when he helped treat a yellow fever outbreak that occurred some years later. So one of the things that I just like to do is tie up or tie together all the things that we just sort of talked about. Modern traumatic brain injury care. Do you think that he would have lived or died? Died. Who says lived? Anybody? Who says died? Vast majority of people. And I think he probably would have died. I think his care was excellent for the time. What do we do nowadays? We obviously want to look for depressed mental status. If the GCS is low, is 8 and below, what are we going to do? I just heard this in the previous talk. There seems to be some neurosurgical problems here. But in general, the National Trauma Brain Foundation recommends for anybody with a prolonged depressed GCS after resuscitation that they get ICP monitoring. You want to monitor them you want to optimize their venous return, so if they have a C-collar in place, you want to loosen that. CO2 management for the immediate care of elevated intracranial pressures. You want to have adequate sedation. Ultimately speaking, if you still have ICP problems, you're going to go on to osmotherapy, possibly decompressive craniectomy, putting them into a coma, and there is some controversy about hypothermia. But this is also a patient who theoretically could go on to organ donation. If you think that they have a non-survivable brain injury, you have to think about organ donation in the end, especially if it's bihemispheric. Let's move on to case number 2. This is a 49-year-old male who was shot in his back with a .44 caliber revolver from a distance of 6 feet. He was vomiting, fainting, and oozing dark red blood from his back and had a feeble pulse of 120, noted to be tachypnic and diaphoretic. His initial treatments included spirits of ammonia and brandy, and the patient was reporting prickling sensation in his right leg and foot. This is obviously a problem. The patient is presenting in some form of shock. I'm not sure. Again, we heard earlier, lactated ringers is the choice for resuscitation in certain circumstances. I haven't pulled out the spirits of ammonia or brandy in quite some time. So I think we've moved away from that. His initial exam demonstrated a wound 2.5 inches to the right of the vertebra and probed with a non-gloved finger. His exam was repeated by multiple other physicians, which demonstrated 4 inches to the right of the vertebra at the 11th rib. It was again probed with an ungloved digit. And that becomes even worse when you hear where they were doing it. Morphine, atropine, water, milk, lime water, and cracked ice were given over a period of time despite his persistent emesis, and he had many wound probings. This was a prolonged period of care for this particular president. He did have some minor improvements, but then ultimately developed fevers and had an abscess which was cleaned with carbolic acid and potassium permanganate. It was incised and drained. The wound was extended. He started tolerating a diet again, and this time the diet was beef juice, toast, hummus, milk, and rum. 2 weeks later, he was noted to have discharge from his ears, mouth, and all the incision sites, and he was not tolerating PO. So they went ahead and did the next most logical thing, which was provide egg bouillon, whiskey, and paregoric via the rectum. So he continued to have weight loss, as you might imagine, and then 2 months later, ultimately speaking, he died of infection. This is James Garfield, our 20th President of the United States. He was a fascinating man. I actually have a separate whole talk just on President Garfield. He was really a self-made man, a brilliant man, and by all accounts, or just a good person. He ascended to the presidency after the Civil War. He was a war hero, and really, really fascinating. My other talk on him is actually called, well, I'll tell you what it's called in just a bit. Does anybody know who this is? Charles Guiteau. Charles Guiteau is the second of our crazies. He is a really interesting character that you could read about. Actually, there's a tremendous amount about him as well. He was a lawyer, he was a preacher, he was a newspaper man, he was also a wife beater, and several other things that put him in prison for a little while. So Charles Guiteau believed at one point that he worked for Garfield's presidency election campaign, which he didn't really do. And he came to Washington, D.C. to get a job because he had no job at the time. And just like nowadays, although probably a little more subtle, where if you help the president out get elected and you get a job, Guiteau, this was the way it was way back when. And people lined up on a daily basis in the White House, which you can no longer do, obviously, and sought work. He was turned down multiple times, and in fact, they felt that he was absolutely crazy. His family wanted him committed, but he was able to get out of that. And the Secretary of the State at the time also said he should never come to the White House ever again. So once he was barred and he realized that he wasn't going to get a job, he turned on Garfield and decided that the only way to make things better was to kill Garfield. So he spent some time figuring out how to do that. He felt that God instructed him to do it, and therefore it was okay. He wrote this whole manifesto, recognizing that he was going to be cited as a hero after Garfield died. So after a failed attempt, actually while Garfield was in church one day, he found out that Garfield was going to be going to his college reunion for Williams College in 1881. And he met Garfield at the railroad, the Baltimore and Potomac Depot at 9:20 in the morning. He approached him from behind and shot. And you heard where he shot into his back, and as you can see depicted on the picture down here, the Garfield holding his back, and they're trying to restrain Guiteau. The first physician arrived within 4 minutes, and soon thereafter 2 more. That's a great response, better than most EMS agencies nowadays. They started with probing of the wound with fingers and instruments. So the interesting thing about this at this point was that although probing of the wound is still something that you hear about, ungloved fingers, at least in Europe, was no longer tolerated. They actually, Lister's view of sepsis had already been talked about and accepted all over Europe, but Americans had not yet accepted it because they felt that Europeans were quacks and had no idea what they were talking about. They brought so he had multiple probings of the wound in the depot of the railroad station after he was shot, both with instrumentation as well as with fingers. Interestingly, they used an instrument with a white porcelain tip, so when they put it in, they could see, and pulled it out, they could see if there was any gunpowder on it, so they could identify where the wound was, or where the bullet was. He ultimately went back to the White House at 10 o'clock in the morning, and as you saw earlier, the patient had vital signs with evidence of shock. Again, he had more wound probings, and they felt that it was the wound was into the abdominal cavity. On July 3rd, multiple other physicians were consulted, famous actually surgeons and doctors at the time who performed wound evaluations. More surgeons were consulted. The famous Agnew of the Agnew Clinic from the painting was consulted and brought, as was Hamilton, who was an expert in gunshot wounds from Bellevue. They were brought in to also take care of the patient. They actually have a diary of their daily probings and care of the president. Interestingly, they refused to have any nursing staff involved with his care. They just wanted to take care of them themselves, and they deviated from what was norm. And this is one of the themes of this. When you have somebody who is famous, you shouldn't deviate from your norm. July 23rd, he had a fever, vomiting, chills, and the wound was eye indeed. On the 26th, even Alexander Graham Bell was brought in. because he had a device called an induction balance, which is almost like a divining rod. It was to be waved over the patient to try to determine where the bullet was. Not that I'm clear what they would have done once they identified where the bullet was, but they brought him in with some equivocal findings. He was sent back to work on his induction balance to make it better for the next time they wanted him. August 8th, first time we hear that a president was under anesthesia. So he had ether anesthesia, where Agnew went ahead and did a wound exploration. 10 days later, he developed parotitis, discharges from his mouth and ears, as well as his incisions, as you already heard. He had a huge weight loss by the 23rd of August. Around the beginning of September, Garfield started realizing that he was never going to survive this and wanted to go to the water he grew up near the water. He really enjoyed the water, so a family friend offered him a house in northern New Jersey, and he left for that house on September 6th, knowing that he was going to die. He fired many of his physicians. Ultimately, he died on September 19th after developing some chest pain, becoming unconscious. This is the autopsy performed on James Garfield. He had a fracture of his 11th rib where the missile had gone left obliquely forward, passing through the body of the first vertebrae. Let me see if I can get this. There we go. So you see here it entered into his back through the first vertebrae and lodging in the adipose connective tissue immediately below the lower border of the pancreas, about 2 to 2.5 inches to the left of the spinal column, and it was found to be encysted. His immediate death, cause of death, however, was a ruptured splenic artery near the where the bullet was, because there was a tear of the artery that was noted. There was also a 4 by 6 inch abscess inferior to the liver, and let's just point out that the liver is not on the side of the splenic artery. On the right-hand side, with pus-filled large intestine, left renal subscapular abscess, and bronchopneumonia. So the multiple probings actually brought it to the point where he had different tracts throughout his back and into his retroperitoneum and abdomen, and then he became floridly septic and died. So a little word about Guiteau himself. He defended himself. He had 3 arguments. One of them was that Garfield died in New Jersey and not in DC, so he can't be tried for a crime that was not, that he died in a state where the crime was not performed. He also, interestingly, and I think this was in some ways brilliant, he actually said the physicians were incompetent. If the physicians didn't probe the wounds and the way they were doing it, Garfield would have lived. And lastly, God told him to do it, and he had the authority of God, so therefore he should not be killed. He was ultimately found guilty and hanged on June 30th, 1882. A couple of interesting things about this: all those physicians who did all the things that were not really standard of care in the world any longer, they charged the president for the first time for their work. Every one of them charged between $3,000 and $6,500, which was a huge amount of money at that time, and I guess fee for service, right? So, and then soon after that, the Secret Service started sending details with the president to guard them. Obviously, his overall care was questionable. Whether or not you want to digitally probe wounds with ungloved hands is not the standard of care. At the time of Lincoln, it was a standard of care because Lister hadn't come up with his theory of antisepsis yet at that point. However, at this time, as I already mentioned, this was worldwide accepted except by American physicians. And as you probably note in modern times, we are behind the curve on a lot of things that come out of Europe and other places. So there was some really questionable care that was performed on Garfield. They didn't really do a great assessment on him. He had actually a couple other wounds. And lastly, nursing care. They took the nursing part of the care out of the equation. And we all know that if you're really good at one thing, you shouldn't be eliminated from it. So there was some overall questionable care. And now I will tell you what my talk is called on Garfield itself. It is called Assassination or Medical Murder because the physicians probably killed Garfield. He may have died ultimately way back when without antibiotics or anything of sepsis anyway, but they certainly had a very big hand in his death. So just a quick word about penetrating torso trauma. One of the biggest things obviously we want to do is trajectory assessment, which is why people like to probe the wounds. You want to find out what is connected. If there are two holes, if those are two things that are connected, what are the structures in between that could be injured? This is how we approach all of our patients as trauma surgeons. If I'm taking somebody up to the operating room, I'm thinking about those wounds and what I'm going to encounter in the operating room. My surgery is planned before I get into the operating room and make my incision. And obviously, whether or not the patient's in shock versus no shock. If the patient is in shock, the patient usually ends up having to go to the operating room immediately without any major imaging. However, plain films are a valuable tool in the armamentarium of anybody who's going to be taking care of these trauma patients, again, to assess trajectory. If they don't have shock, you have time to play and you have time to understand things a lot better. And likely they don't have any major vascular injury if they're not in true shock when they're coming in. They might have bowel injury or something else, but they don't have a major vascular injury. Let's go on to case number 3. This is a 58-year-old male who sustained 2 .32 caliber wounds to his torso. On exam, he had a wound to the right of his sternum between his second and third ribs that were deemed to be not penetrating too deeply, and a deep wound into the abdominal wall located halfway between the line drawn from the umbilicus and nipple line and 2 inches to the left of the midline. He underwent an exploratory laparotomy where they identified a stomach injury with a large amount of spilled gastric contents that was ultimately repaired. His incision was then closed. Post-operatively, he remained tachycardic, tachypnic, and febrile. He was given morphine for pain, digitalis for tachycardia. Again, the nutrient enemas are a theme. Several days, I bet you we'd get a lot more patients out of the hospital if we started doing that. Several days later, after some initial improvement, there was some wound discharge. The sutures were removed. Again, normal wound care when you see or suspect an infection. The wound was cleaned with peroxide. He was doing a little better, started tolerating a diet, and was given a cigar. However, his tachycardia returned, which was treated with DIG again, strychnine, subcutaneous saline. Ultimately, no resolution, so he was given whiskey, camphor, adrenaline, nitroglycerin, and oxygen. This is William McKinley, our 25th president. He was the last of the Civil War alumni to become president of the United States. He was attending the World Expo, or the Pan American Expo in, anybody know what city? Buffalo, New York. And you'll actually hear some physicians that still have their names on things in Buffalo, New York as it relates to his care. Let's see. So what happened to him, the person who assassinated him was a guy by the name of Chol Gulch. I butcher his name every single time, despite the fact that I practice it, sorry. He was an avowed anarchist, and to beef up his credentials, he decided that he was going to kill the President of the United States to become famous in anarchy circles. So he found out that the president was going to be at the Pan American Expo in Buffalo and approached him with a gun that was wrapped in a towel. Most people thought that he was actually just coming to shake his hand until he removed the towel and shot him. There was actually a bodyguard for the president with the Secret Service. They were standing about 5 to 10 feet away from the president when he approached. There was also an army regiment that was there that was unarmed and unable to do anything about it as well. So at 4:18 p.m., and just note the time because it becomes sort of important, an actual ambulance arrived, so it's the first time you're hearing about ambulances and taking people different places who were injured as it relates to presidential assassinations. They took him to a special hall at the expo site, and they started looking to work on the president. At 4:45, one of the president's physicians arrived, followed by 5 other doctors, including a Dr. Mann, who is an OBGYN. For unclear reasons, the OBGYN was put in charge of the care of the President of the United States, who had no experience really operating inside the abdomen. They had no instruments except for Dr. Minter. When he arrived, he had a small set of pocket instruments. And it was also, the sun was setting at 4:15 p.m. It was starting to get dark, and this is the room. So what happened, the surgeons actually scrubbed this time. It's a number of years later, and the surgeons cleaned their hands. They shaved and scrubbed the president. Again, for the second time now, you're hearing the president is going under anesthesia. But because of the anesthesia, they couldn't light candles as it was getting dark. So another physician arrived, and his job was to assemble the mirror to reflect the light from the window so that they could actually operate on the president. His upper wound was determined to be very superficial, and his lower wound was felt to be into the abdomen. They made an upper midline incision, very small at first, and found some bits of clothing and then an anterior gastric wound that they closed with silk. Somebody reminded them that they should look at the back of the stomach, so they extended the incision and looked at the back of the stomach and found a wound there, which they closed. Dr. Roswell Park, again, the cancer center guy from upstate, he arrives. He had a certain amount of experience with gunshot wounds at the time, but the OBGYN overruled him over several things, including about leaving drains in his abdomen. The abdomen was closed after the debridement. At 7:32 p.m., he was transported to a private house. Back then, hospitals were actually felt to be dirtier and places to die and for poor people rather than places to heal. So patients who were wealthy were often transported to private houses. His pulse rate was 127. He had a mild elevation in his fever and his temperature, and his respiratory rate was 30. As you can see, again, this is a guy who is at the very minimum SIRSI, if not already septic. More doctors arrived. The McBurney of the famous McBurney point for appendicitis arrived. Now Bellevue nurses were sent, and they started taking care of the president in terms of his wounds. He was given, as you saw before, morphine and DIG. Dressing changes and nutrient enemas continued, but by the September 9th, his heart rate had started to come down. He did have a bit of a fever. Respiratory rate was still elevated, but he didn't really have any pain, and he was having bowel movements. There was so much encouragement from the team that was taking care of him that the Philadelphia Medical Journal wrote, "We have strong grounds for the hope that this valued life will be spared to us for many years to come." Pretty much a day later, he started having discharge from the wound where they opened the sutures. He started on a diet, which we noted already, but on the September 14th, he died at 2:15 in the morning after becoming increasingly restless and shocky. So he had an autopsy as well for unclear reasons. After 3 or 4 hours, his wife stopped the autopsy after they found necrosis of the stomach, pancreas, and a laceration of his left liver. To this day, nobody really knows why she stopped the autopsy, but that's all they found. The perpetrator, the anarchist, was obviously found guilty, and he was killed. And then his body was burned with sulfuric acid so as to destroy any evidence of him so that the anarchists couldn't go use him as a martyr. Ultimately speaking, his care was maybe not great, maybe not amazing, maybe not exactly poor. The lighting was a problem. Instrumentation was an interesting thing. So, number one, when you think about a room that you want to operate on somebody, maybe you don't want to bring it into a room that has almost no windows and it's not the right time to do it. But the instrumentation, if you could prepare for these things, as we'll talk about later on, that might have made a difference, where they were using pocket instruments, less than ideal instrumentation. It turns out that in a room just next door was a full surgical tray of equipment that nobody had communicated to the team that took care of him. While we debate nowadays the concept of drains were utilized at that time, but was overruled by somebody who was not trained to take care of this type of patient. The physicians again started charging, or were charging the government for the care of the president. At this time you can see they upped their ante just a few years later. They're making now between $6,000 and $10,000 for the week of work that they were doing. Moving on to our second to last case, this is a 46-year-old male patient who was shot by a 6.5 millimeter carbine Mannlicher Carcano rifle while in a motor vehicle through his neck and head. He arrived at the hospital within 4 minutes. Noted to have slow agonal respirations and an intermittent heartbeat by auscultation, but no palpable pulse or blood pressure. They noted 2 wounds. One is in his anterior neck, just as described, just above his thigh. And a large avulsion in the right occipital-parietal region. Both were bleeding and brain tissue noted. Again, I want you to think about whether or not what you would do with a patient like this if they rolled into your emergency department. There were multiple attempts at intubation where they noted a tracheal injury, and they went ahead with a tracheostomy. He had right lower extremity and left upper extremity cut downs. Again, you see a sort of transition about the way we're gaining access on patients and the way we're taking care of patients. We don't really do cut downs anymore. I know at least our residents in emergency medicine in our hospital still practice that on our cadavers, but nowadays with intraosseous so prevalent, I don't know that anybody, I haven't done a cut down in like 100 years. He was given 300 milligrams of Solucortef because, interestingly, one of the physicians who was there had heard that President Kennedy had Addison's disease. So with him in shock, they felt that giving steroids would be a good thing. They obviously initiated CPR, but ultimately speaking, and only several minutes later, his eyes were noted to be deviating laterally with fixed and dilated pupils and no deep tendon reflexes. So he was pronounced dead. He was actually, they stopped resuscitation efforts but didn't pronounce him for a little bit because Jackie Onassis Kennedy, or Jackie Kennedy I guess at the time, she wanted a priest to be there before they pronounced him dead. So obviously this is John F. Kennedy, the youngest man to be elected president of the United States. This happened on November 22nd in 1963. He was going through Dallas in an uncovered limousine with Governor Connolly in the front seat and his wife to his left. 3 shots were reportedly fired. The first one was missed. There's huge conspiracy theories about this, obviously, as you all well know. The second one went through his neck and into Governor Connolly, who was sitting in the front seat in front of JFK, which injured ultimately his ribs, right lung injury, fracture of his distal radius, and he had some soft tissue injury to his thigh. And then the third one into JFK in his right occiput. The president, ended up 4 minutes later at Parkland Memorial Hospital. You've already heard from Parkland this morning as well. There's a lot of overlap today. Parkland formula comes out of this area. He arrived very, very quickly. Obviously, they did not wait for any ambulance or any other thing. They just drove right to the hospital. The picture up there is Dr. James Carrico, who at the time was a PGY2 surgical resident staffing the emergency department. I could only imagine what I would be like if I was a PGY2 and the President of the United States coming with his head blown off. But by all accounts, they did a great, great job, everybody. There were a huge number of people who actually responded to this. At the time, there were really no pagers, so there were overhead calls and telephones that were utilized to mobilize people. The chiefs of staff of almost every department were converged into that room where they made certain decisions, but ultimately the neurosurgeon in-house saw what was going on with his head, and that's when they ceased any further efforts at resuscitating him. These are just remarks from the record, which is found in the Warren report, as well as several other sources. He had slow spasmodic respiratory efforts with a heartbeat, but no pulse or blood pressure. 2 external wounds were noted, as I described before. Endotracheal intubation was attempted. He was placed in Trendelenburg. They went ahead with a cut down in order to gain access and gave him lactated ringers as well as uncross-matched blood and the hydrocortisone that I had already spoken about. Because of the tracheal injury, they felt that they couldn't get the intubation, so they performed the tracheostomy. They also noted some bubbling around the wound, so they felt that maybe there was a tracheobronchial injury. So they placed bilateral chest tubes in JFK, and ultimately he went into a full cardiac arrest and performed CPR with an EKG rhythm demonstrating asystole. There was noted to be 1,500 cc's on the op report that they wrote afterwards of blood on the floor on the drapes, and there was a considerable loss of scalp and bony tissue, and he was pronounced very, very soon thereafter of arriving in the hospital. His autopsy, these are pictures. He had a massive head wound located 2.5 centimeters to the right and slightly above the external occipital protuberance, measuring 5 by 6 millimeters in diameter, with an exit site in the right parietal, occipital, and temporal regions, measuring 13 centimeters at its greatest diameter. So this was a very powerful rifle. Lacerations in the brain exposing interiors of the right and third ventricles. He also had a 7.4 millimeter oval hole, 14 centimeters below the mastoid process, just above the border of the scapula, entry site of the neck wound, exit wound at level 3 and 4 tracheal rings. These are radiographs of the wounding of his skull, which you can see with the tremendous destruction. His care really was excellent. And if you want to really nitpick, they didn't log roll him and identify all his injuries, but ultimately speaking, when somebody's dying, I'm not sure that any of us really log roll all of our patients. Oswald, who was his killer, or supposed killer, depending on whether or not you believe the theories, was a communist, and this was his way of showing his dedication to the Communist Party after he was kicked out of Russia, essentially after he lived there for a time. He was apprehended and then shot in a movie theater by Jack Ruby, who was a nightclub owner, and Oswald died in the same hospital that JFK did in the operating room, however. Connolly lived. Last case, this is actually not an assassination, it is an attempted assassination, but I find this one amusing on several levels, mostly because of the pure politician that this president was. A 70-year-old male with a GSW to the left posterior axillary line at the fourth intercostal space. He was actually responsive and alert with an 80+ palpable radial pulse. He had chest pain, some ashen color, pallor. Blood was noted in his mouth and on teeth. O2 and 2 units of packed red blood cells were given immediately. He was found to have no breath sounds over his left hemithorax. A chest tube was placed, which put out 1,200 cc's initially. Ultimately, every 15 minutes, he put out another 200 to 300 cc's of blood, and was given 3,000 cc's of crystalloid in the emergency department and 2 units of packed red blood cell with some good blood pressure response. He was taken to the operating room and fixed, which we'll talk about in just a minute. I really love this picture. It's like he's saying, go ahead, shoot me, I'm still going to survive. So Ronald Reagan was shot on March 30th in 1981 by John Hinckley. Does anybody know why this crazy did it?
For love.
For love, yes. Jodie Foster, that's correct. So he wanted to impress Jodie Foster. And for those who don't know who Jodie Foster is, she's an actress, but that's why he decided that he was going to kill the president. There were multiple shots fired. Bullets striking the president ricocheted off the armor-plated limo. Reportedly, Ronald Reagan's one of his first fun lines was, "What the hell is that?" And he also was reported to have said that he felt a pain in his upper back that was unbelievable. It was the most excruciating pain he had ever felt. He was then thrown into the vehicle by the Secret Service agents, who then jumped on top of him. And he said, "Get off, I think you've broken one of my ribs." The video's not working, I apologize. So they noticed red frothy blood coming from his mouth, and they weren't actually going to the hospital at first. They were just getting out of the warm zone, the hot zone. But when they saw the blood, they decided to divert to a hospital, which happened to be GW. He got there at 14:35, and in the emergency department, he was his charming actor, politician self. one of the nurses was holding his hand apparently, and he asked who's holding my hand, and does Nancy know about us? When Nancy Reagan did show up, he said, honey, I forgot to duck. But the medical care goes on, and he had his chest tubes placed after seeing some fluid in his chest x-rays. A lot of this is really obviously just contusion, you can see some bullet fragments sitting over here. They did put it in the chest tube, and as I noted on the previous slides, he put out a large amount of drainage, so they decided that they were going to take him to the operating room for several reasons. Not the least of which was there was somewhat of an indication to do so, but they also felt that leaving a bullet in the sitting president may not set the right example. I think the opposite. I would say, like, screw you, I won. And I still have the bullet in me. But lastly, they wanted it for forensics. They actually did a DPL on him to make sure that there was no intra-abdominal components. And again, think about how things have changed. We don't really do DPLs very often anymore. There are still some indications as far as I'm concerned, but not the usual. A left anterior lateral thoracotomy was performed in the operating room where they drained 500 cc's of clot. According to Tim's lecture, we probably should have just waited and done a VATS on him to evacuate his clot. The bullet was located and removed, which is, I think, actually no small feat in most instances. The lung parenchyma was injured and was sutured, although he did have an air leak. Ultimately speaking, he lost between 3 and 3,500 cc's of blood. He was given, and this is what I want you to also focus on, he was given 8 units of red cell, 3 of FFP, and 1 of platelets. Now that's not bad that he got blood products, but maybe it's not the ideal number and ratio of blood products that he was given. So just before he went to sleep, right before anesthesia put the mask on him, he said, please tell me you're a Republican, and the anesthesiologist replied, today, Mr. President, everybody's a Republican. Ultimately, again, this is all lore. Hospital course, he had some hypoxia for a bit of time, but ultimately responded to some PEEP and recruitment maneuvers. Again, while he was being treated post-operatively, he asked if we could rewrite the scene beginning at the time he left the hotel. Lastly, he also said there was no more exhilarating feeling than being shot at without result. Ultimately speaking, he was extubated on March 30th at 3 o'clock in the morning, which most of us won't even do anymore, and then at 6 o'clock in the morning he went to the ICU with a small air leak and very little bloody drainage. This is a cartoon depiction of the injuries that he sustained. It was felt that the trajectory hit a rib and then sort of bounced into his lung, into the hemithorax, the left hemithorax, and you can see here where it sort of lodged, just next to the pericardium. So he went to the presidential suite, and very soon thereafter his air leak ceased. However, he did develop some fevers. He was treated for a pneumonia, really, with cephalosporin after bronchoscopy. He had an increasing white count, however, and way back then they were giving gamma globulin and beta globulin when they were suspected infections. His pneumonia ultimately resolved, and oxygen was weaned, and he was sent home on April 11th. He had 2 outpatient follow-ups just in the White House, and he was fine. The next pictures are just a few from what's going on. John Hinckley, arrested, and for those of you who follow the news, was relatively recently released from his prison term. I don't think he ever hooked up with Jodie Foster, just as a postscript. These are just some other pictures of his x-rays, and this is the bullet that they found. These are x-rays through his hospital course, where you can see some significant haziness in the lower lobes on the left-hand side and clearing up over the treatment course. And this is the last x-ray upon discharge from the hospital. So you can see there's still some lung area that doesn't look great. Oh no, I'm sorry, this is the one from 5 months after the shooting. So still fairly hazy, not a great really looking film, but they did nothing about this, and that's it. So just a quick word about chest trauma, and then I'm winding down. Chest trauma, the vast majority of them do not need surgery. They usually need just a chest tube. But you do have to know the triggers for surgery when you do place a chest tube, and those triggers are anywhere from 12 to 1500 cc's or 2 to 300 cc's per hour for the next 4 hours. So he didn't quite meet those criteria. The take-home message, though, I would leave for you guys is that the absolute numbers are not important. The general range of numbers are important. So if you see 1159 cc's coming out of somebody and they're unstable and they don't look good, they probably deserve to be in the operating room. Whereas some other people, if they have 1200, if they put out 1300 and then their chest x-ray is perfectly clear and they're hemodynamically stable, maybe they don't need an operation. So just understand that although there are suggested triggers for it, it's really the clinical picture that is what we should go for on a day-to-day basis. The last few slides, just to wrap all of this up, is talking about really how we take care of the president nowadays. There are no true standards around the world, but there is in the United States something called the White House Medical Unit. Originally, the president was taken care of really by their primary care physician, but it evolved from a side job to an appointed position over a period of time. And then in 1945, the White House Medical Unit was officially created. It's staffed by 1 to 2 physicians from each military branch, also associated nurses, physician's assistants, medics, and corpsmen. And they're stationed in the White House, and what they do is to provide comprehensive medical care and emergency action response to the president, vice president, and their families. They do a whole lot of stuff just besides taking care of them. They do global medical intelligence and medical planning, so I'm assuming that when the president comes to Brooklyn, this is one of the hospitals that might be tapped to take care of him, yes?
It was back in 1976.
Oh, okay, 1976. So way back in 1976, the White House Medical Unit sent an advance team to this hospital to make sure that they had the appropriate care involved to be able to take care of the president. They provide travel medicine support. They also provide support for anybody in the White House, really, if there is somebody who takes ill. They perform training and personal development. They have a saying, which is no policy, no politics, just trusted medicine. Most of their physicians are either primary care physicians, and nowadays many more emergency physicians. There is no dedicated surgeon to the White House Medical Unit. They staff not only the president, but anybody in the White House, as I already mentioned. They perform medical contingency for each trip. In fact, they were just in our hospital because Obama was in Newark, and they needed to make sure everything was okay, so they come by with the Secret Service, and they do a full walkthrough of the hospital from the time the president would be walking through the doors of the trauma bay to the operating room or CAT scanner where they want to see the ICUs and what the capabilities are. There's also a full document that has to be completed for each one of these trips. Interestingly, for those who don't know, Air Force One has an operating room table on it, and the president travels with his own blood, and there's a rapid response bag with a huge amount of material in it that they could utilize. The White House Medical Unit has evolved just like trauma care has evolved over the period of time, very specifically through 3 presidents. JFK was the first one where they started realizing that they needed to work with Secret Service in terms of trying to get cooperation, because there was a lot of issue with the care of the president as he arrived in the hospital, and who was taking care of him, who was in charge of who could come into the room and who could go out of the room, and so on and so forth. Reagan was the one where they realized where they had to designate a hospital for the president. So pre-planning, as I tell my residents all the time, perfect planning leads to a perfect procedure. Understanding what hospital you're going to go to takes the guesswork out of where you're just going to show up to if, God forbid, something happens. And then Clinton was a very young guy when he was president and traveled all over the world. He was one of the, at the time, he was the most well-traveled president. So they needed to be able to provide his medical care for him all around the world. The Capital Program is a joint venture between the White House Medical Unit and the American College of Surgeons Committee on Trauma. They work together identifying trauma centers around the country and providing the information that they need in order to have these advanced setups for the president. So just lastly, would they have survived today? Abraham Lincoln, we sort of said, maybe, maybe not. Garfield, I think today, yeah, would have survived. McKinley would have survived. JFK, not at all. And Ronald Reagan obviously survived. So just to summarize, assassination attempts are clearly not unheard of. They're actually nowadays becoming more and more common. Standards of care should be practiced at all times. You don't want to, eliminate the nursing staff, for instance, when that's what they would normally do, is care for the wounds. Or you don't want to bring in chiefs of staff when they haven't done a primary survey on somebody in 100 years, and all of a sudden they're the ones who are doing that because it's the President of the United States. You want to keep your teams together. Use the appropriate personnel and equipment, and then, again, perfect preparation leads to a perfect outcome or procedure. So I just want to thank my partners who allowed me to travel across the country and give this talk and cover my patients for me, and Mark Silverberg, who I have known since really day one of college. He was across the hall mate of mine. Not only did we play Tetris together on many occasions, but we did some serious drinking. Are there any questions? Well, that's it.